So with that, I have the pleasure of introducing Dr. John Kellum, who's our plenary lecturer. Dr. Kellum did a lot of his original training in Ohio and then did his internal medicine training at the University of Rochester before going to the University of Pittsburgh, where he's been for a number of years now, having completed his training in critical care, and then also joining the faculty where he's risen to the ranks of professor of critical care medicine as well as professor of bioengineering and part of their clinical and translational science research program. They also have a department of critical care, and he's the vice chair, or one of the vice chairs in their department at that place. So he's a very well-known person. He's an expert in acute kidney injury and critical care as an intensivist. He's lectured all over the world, published hundreds of articles on each of these topics. He spoke earlier this morning on the main Emory campus about kidney injury and different fluid types. That's one of his passions and something that he's been working on for many, many years. But now here at the summit, he's going to talk about acute kidney injury and some of the biomarkers that are coming out to help us to better identify patients that are developing or will develop acute kidney injury so that we can manage them better. So John, thank you very much for coming to Atlanta and giving us your thoughts.
Thank you. Thank you. Thank you very much. Thank you for that warm introduction. When you get to a certain part in your career, they stop mentioning dates. They just say things like, it's been in Pittsburgh for a long time. So I guess I'm there. But thank you very much, Greg. It's a pleasure to be here and to talk about a topic which I think, and of course I'm biased. It actually should be on my disclosure slide that my bias is that we don't pay enough attention to this problem. So I'll just say that to begin with. I think that this is a problem which we've not paid adequate attention to. My disclosures include Acute Medical, and I am going to talk about a biomarker which they developed. I may, in passing, speak about some other biomarkers which other companies have developed as well. And I'm also obliged to tell you that the University of Pittsburgh, the University of Munster, and Acute Medical have filed have filed a provisional patent application on the use of biomarkers in conjunction with remote ischemic preconditioning. And I don't know whether that conveys to you that what I tell you might be suspect, or whether it should impress you that there's enough science there that companies and universities have gone through the trouble of trying to protect it. But in any case, I will be talking about that briefly. I actually get to begin this talk by doing something which I rarely ever get a chance to do, which is to actually quote the FDA in a positive way. And so I'll just read you what it says. This is from the press release that the FDA put out when they approved the marketing of the TIMP2 IGF-BP7, the so-called Nephrology test for the detection of acute kidney injury about a year and a half ago. And they said early assessment and timing and timely treatment for AKI can help prevent kidney damage and potential associated complications. The Nephrology test provides healthcare workers with a quick and validated method for assessing patients' AKI risk status, which may inform patient management decisions. And I think that the FDA actually got this right. I think that it is important to test for the development of acute kidney injury, and it is important to think about whether the information that you get from various tests would change practice. But of course, there's where the rubber meets the road, and of course, you all are responsible for changing practice, and the questions that you no doubt have are, what is it that I can do that with this information that would change outcomes? And I hope to be able to persuade you over the course of this talk that actually there are things that we can do and that we should be doing them, and that we're currently not doing them, at least for all of our patients. Well, the first issue is that this is actually a really big deal, and we've even tried to change the conversation a little bit. Heart attack and brain attack are sort of known well in the population at large, that people understand what they mean. no one understands what acute kidney injury is outside of the medical community, and not even the medical community at large necessarily understands what acute kidney injury is. And so I'm not suggesting that we should just go ahead and whole-scale change the term in our medical literature from acute kidney injury to kidney attack, but it might be useful to use words that are better understood by our patients. And kidney attack at least puts forward the essential meaning that the kidney's being damaged, that it's acute, and in fact, there is some sense of urgency about fixing the underlying problem. It's estimated that about 3 million to 5 million patients around the world will actually die attributable to acute kidney injury. I'm not going to show you how that calculation is derived, but suffice it to say that millions of patients every year develop acute kidney injury. And there's really not a lot of directed therapies. There's not a specific, you can't just send them to the cath lab and open an artery. You can't send them to surgery and do something. You can't give them a magic elixir. So the strategy for approaching this problem is really more complex, and that's really where we really need to focus on a series of things that we can do and not do, as it turns out, that will improve the outcome of these patients. The other thing I want to convey to you is this is not just an ICU problem. I'm an ICU doctor. This is a problem that we see a lot in critical illness, and in fact, upwards of 2/3 of all of patients in the ICU develop acute kidney injury. But this is not an ICU problem only. This is a study we did some years ago that Derek Angus led, in which we looked at pneumonia patients coming into the emergency department with pneumonia and then being admitted to the hospital. And only about 16% of this cohort ever went to the ICU, only but 10% of these patients were ever on vasopressors, just to give you some sense of what this population is. So this is community-acquired pneumonia coming into the hospital, not critically ill patients. And in fact, the non-critically ill portion of this population has just as big an impact on, AKI has just as big a relative impact as it does on the patients in the ICU. And you can see that, particularly as you go out 1 year, that acute kidney injury is associated with a really massive increase in mortality for these patients for reasons we don't completely understand. It's not just driven by development of chronic kidney disease. If I came to a meeting like this, even just 5 or 6 years ago, and I said, these patients are developing chronic kidney disease, there would have been a lot of skepticism, and I think we now understand that that's actually true, that a lot of these patients they're left with chronic kidney disease because they don't recover renal function when they leave the hospital. Of course, we understand that if you have chronic kidney disease, that's a really big deal for mortality in the coming years, because that's the biggest risk factor of all the Framingham risk factors. Chronic kidney disease trumps everything else. So so just think about it for a second. If I develop acute kidney injury and I leave the hospital with new chronic kidney disease, meaning my eGFR is less than 60, particularly if it's less than 30, that's a risk factor that trumps diabetes and hypertension and smoking. In fact, it's more than any two of those other ones put together. So that means that if the patient comes in and they leave the hospital with chronic kidney disease, that's like leaving the hospital a smoker and a new diabetic in terms of the risk of cardiovascular events over the coming 5 years. So we understand some of that, but we even see patients having increased risk of death even if they appear to return to normal renal function at hospital discharge. And we don't understand that at all. And we don't understand the acute mortality. This is where we stand. In fact, this slide's a little out of date. The numbers are even a little bit better for these other organ failures in the ICU. Sepsis rates, as you've heard, the mortality rate associated with septic shock, as you've heard earlier in this meeting, composite mortality rates down around 18-19%. For hospital mortality, acute lung injury down around 20-22%. Cardiogenic shock was a death sentence when I was in medical school, which was a few years ago, but when I was in medical school, it was a death sentence. It's now, with the advent of VADS and everything else, hospital mortality is down around 12-14%. But this is renal failure. This is acute kidney injury at KDIGO stage 3 or rifle F. Our patients are dying of a disease process which we really don't really fully understand. And even if you say, well, is that really because the kidney injury is killing them, or is it just a marker of everything else that goes on for these patients? And it's probably a bit of both. But clearly, this is a huge unmet clinical need. This is a huge lurking threat to our patients. And I don't know how well that projects in the back of the room, but there's a lurking threat there. Hopefully, you can see. And we're the very relaxed, intensive care physician here who's somewhat complacent to this looming threat. And so some years ago, we put forth the rifle criteria, and then we modified it a few years later because we realized that if you started out with a high baseline creatinine, you shouldn't have to have a 50% rise. You shouldn't have to go from 2 to 3 to call that acute kidney injury. And so we added a change that's less than 50% as long as it's an acute observed change of 0.3 milligrams or less. And that holds up pretty well. It's not perfect. But it seems to be better than other approaches. Now, if you use the 0.3, you have to have a documented change in the 0.3 over 48 hours. And I would add, it's not in the criteria, but I would add another caveat that 0.3 rise has to be above the patient's baseline. One of the problems we've seen in this 0.3 criteria is that we'll see patients coming in with, say, a creatinine of 2, and let's say they have a baseline creatinine of 2, and they come in with a creatinine of 2, and then they get a bunch of fluid resuscitation because, of course, we can't stop ourselves from giving liters and liters of fluid. We'll talk about that some more later. And the creatinine comes down to now 1.7 because we've diluted it, and now it comes up in the next 40 hours back to 2. Well, technically, that fits the criteria for acute kidney injury. And in fact, some of our sniffers, some of our electronic medical record systems that go ahead and find these patients have identified these patients as having quote unquote acute kidney injury, and yet they don't. But the other part of this that I want to leave with you is these are not, just like a myocardial infarction is not defined by a change in troponin, or a myocardial infarction is not defined by a change in EKGs. It's a clinical diagnosis. And AKI is a clinical diagnosis. And just to give you some sense of that, this is the KDIGO criteria broken out by urine output and creatinine in about 30,000 ICU patients. And if you have acute kidney injury, and see if I can actually make this pointer work without changing the slide. There we go. I am trainable. If you have a urine output criteria, either stage 1, stage 2, or stage 3, and no creatinine elevation, no change at all, you can see that if you have just stage 1 by urine output criteria, but no creatinine criteria, although this is statistically significant, this transient oliguria that this patient has, this mortality signal actually is statistically significant. This oliguria signal, when it's transient, when stage 1 is less than 6 hours or 6 hours or less, is not really associated with much of a difference in outcome for this stage 1 on the background of no creatinine. But look what happens if you go, for example, you have some creatinine elevation, you have stage 2 by creatinine, so your creatinine is now double its baseline, and now I add oliguria, the same 6 hours of transient oliguria, my mortality rate doubles. It's highly statistically significant. And in fact, it's associated with long-term outcomes. So there's a lot of clinical adjudication that goes into this, right? We know that some oliguria is just a patient who's dry. And we also know that some oliguria, particularly when it's superimposed on top of azotemia, is card-carrying kidney injury. Even some oliguria, if you have profound persistent oliguria, so this is a patient, these are stage 3s, which means either anuria, less than 50 cc's per 24 hours, or 24 hours of less than 50 cc's per 12 hours, or 24 hours of less than 0.5 per kilo per hour. These patients have a profound increase in their mortality, and yet their creatinine doesn't bump. When I first saw that, I thought, oh, well, these are patients that are just dying quickly, right? They die before they rise their serum creatinine. Well, no, actually, the mean ICU time from the diagnosis of AKI to mortality in these patients is about 12 days. So that's not it. and yet they never bump their creatinine. Well, maybe they go on renal replacement therapy. Well, no, only 1% of these patients go on renal replacement therapy. So that's not it. What's happening to these patients? And it's associated with long-term hazards. So what is this? It turns out that you actually have to lose half of your renal functional mass, 50% of your kidney function, before your creatinine even changes. And we know this because you can donate a kidney and nothing happens to you lose half your functional renal mass just right then and there, and nothing happens to your serum creatinine. So creatinine is a very insensitive measure amongst healthy people. Urine output is a very nonspecific measure, but it's highly sensitive. So there are some of these patients who have, and remember, to have profound oliguria for 24 hours in an ICU is pathologic, unless, I don't care where you are. That's not something we typically see. So the reason that profound oliguria is associated with a bad outcome, even in the absence of serum creatinine, probably is because serum creatinine just doesn't pick it up, and you still have card-carrying acute kidney injury. Interestingly, and I'm going to talk about biomarkers a good deal more, it turns out the biomarkers provide a lot of information on this. So this is the biomarker that I began talking about, the one that's recently FDA approved, TIMP2-IGF-BP7, and I'll talk more about this, the origins of this marker in a second, but just because it fits here with the oliguria story, I'll show you that if you have very low, if you have isolated, so the way this is set up is that I'm comparing isolated oliguria, which is the orange, versus isolated azotemia. And so this is stage 1 or better, so this is either a 50% rise in serum creatinine, that's azotemia, or oliguria, 6 hours of oliguria. And I've said, okay, and because it's isolated, there's no creatinine with the oliguria, no oliguria with the azotemia. And then I've said, okay, if the biomarker's low, if you have an isolated creatinine elevation, that's still significant. Now, of course, that all might just be chronic kidney disease risk, and the endpoint here is death, dialysis, stage 3 AKI in 7 days. But if you have oliguria and nothing else happens, then that's benign. There's no risk of going on, no increased risk of death, dialysis. In fact, it looks like if anything, the risk is lower than 1, but that's not statistically significant. Whereas if your biomarker's elevated, you have a profound increase in risk, which means that not all oliguria is the same. And just like the prior slide where I showed you from the large epidemiologic study that the combination of azotemia and oliguria is much more significant than just oliguria by itself until oliguria is profound. So transient oliguria not typically that significant. But here, if the biomarker is positive, you're still likely to be dead on dialysis or develop stage 3 AKI within 7 days if you have isolated oliguria. So there are even our patients, and this was about 30% of the cohort, there are patients with small degrees of oliguria who don't bump their creatinine and yet still have profound kidney damage by biomarkers. Now, why is this going on? And what's the link to oliguria, and why do we care about that, and where's creatinine coming from, and what's the etiology of AKI, and how does it relate to all of this? So the first thing to understand is AKI is not, despite what you learned in medical school, is not caused by, in the vast majority of critically ill patients, is caused by under-resuscitation. It's not caused by lack of renal blood flow. Now, if you put a clamp on the renal artery, you will develop AKI, no question about that, but most of our patients don't develop AKI for lack of renal blood flow. Now, it took me a long time to come to terms with this, okay? I'm an intensivist. Fluid is my drug, okay? I mean, that's what I give patients, right? I mean, that's what I do. I resuscitate people, okay? I killed every one of my houseplants when I was in college because I had one therapy, you know? The leaves drooped, I watered, the leaves turned brown, I watered, I fluid resuscitated everything. And my mother came, it was like a spring break or something, and my mother came, and she came into my dorm room, there's all these dead houseplants, and she said, there's other therapies besides fluid resuscitation, there's vitamins, let's work on this. So yeah, it's a bit like that for the kidney. You will develop kidney injury if you have profound hypovolemia for prolonged periods of time. You will develop kidney injury if you put a clamp on the renal artery, as the vascular surgeons sometimes do. But that's not the typical cause. So what is the typical cause? It actually turns out that most of our patients in the ICU probably have more of a toxic renal injury. toxic from the drugs that we give them, and by the way, you give a lot more renal toxins than you realize, and you give them in combinations where in isolation they're not that important. For example, did you know that piperacillin and tazobactam is nephrotoxic? Did you know that? Yeah, you knew that. Good for you. Most people don't know that. And so there are a lot of drugs that we give that have some nephrotoxic potential, and particularly when it's done in combination with other drugs that are nephrotoxic. There's synergistic nephrotoxicities. That's part of it, but also PAMPs and DAMPs, pathogen-associated molecular patterns like LPS, and damage-associated molecular patterns like HMGB1 get filtered at the glomerulus and signal toll-like receptors in the proximal tubule that then produce a cascade of inflammatory response in the proximal tubule where the injury is occurring. Now, why does that matter? Well, it turns out that even one proximal tubule epithelial cell reacting to one molecule of LPS can set up a cascade, an alarm cascade, by signaling other cells in the area to protect themselves, to downregulate their metabolism and stop transporting solute. And in fact, when you stop transporting chloride, you deliver more to the thick ascending limb, and through tubular glomerular feedback, you turn GFR off in that nephron. And if you do that 100,000, 500,000 times, 2 million times across your kidney, you develop a clinical manifestation of AKI. So it actually turns out that the kidney is exquisitely sensitive to a lot of the environmental exogenous and endogenous toxins that are in the environment. And of course, unlike any other organ, the kidney, unlike even the liver, the kidney has to concentrate this in the proximal tubule effluent. So all those evil humors that are in the blood in a patient with sepsis, for example, are being not just excreted in the urine, but concentrated in the proximal tubule, whereupon the proximal tubule epithelial cells have the molecular machinery to detect and react to those molecules. It turns out that for reasons we still don't completely understand, the kidney is a sensory organ. The kidney actually has olfactory receptors. Yes, the kidney smells stuff in the blood and reacts to it. No kidding. And it doesn't stop there. If you turn down your metabolism, you also go into something called cell cycle arrest, where you do not go into cell cycle when other cells in your neighborhood are lost. So you've heard of renal tubular epithelial cells. So it's the tubules are an epithelium. Even though they're inside the body, it's an epithelium, just like the skin. And just like skin cells are easily sloughed off when there's injury, like a sunburn, et cetera, epithelial cells in the proximal tubule are sloughed off. They lose cation connections to the basement membrane and they're just sloughed off. Sometimes viable cells are sloughed off. Normally, we replace those cells because adjacent cells then multiply and they just fill in the gaps. But when they're under threat, when the kidney cells are detecting injury or damps in the circulation, or nephrotoxic medication, they can say, it's not safe to replicate, so I'm gonna just let this scar down. I'm gonna bring in fibroblasts, and I'm gonna fill the hole that way, because that's safer for me as a kidney cell. It's not necessarily good for the organ, though, because if I do that enough, I develop chronic kidney disease. So all these things turn out to be tied together. Now, given all of that, it was really exciting to us when we did this study, and we measured urine and plasma in hundreds of patients, thousands of patients, and we actually looked at about 300 different molecules in the blood and in the urine. And what we found were two molecules, and this was the study design, so we started out with 3 cohorts and we combined them, and then we looked at the development of AKI, and then we looked at 2 biomarkers that were above all the rest, and then we conducted a validation study. And the 2 markers were tissue inhibitor of metalloproteases 2 and insulin-like growth factor binding protein 7. And of course I said, oh, well, of course, tissue inhibitor of metalloproteases 2 and insulin-like growth factor binding protein 7. It makes perfect sense. No, I didn't say that. I said, I never heard of these molecules. Why should they be the ones that predict acute kidney injury better than anything else? And so we started looking at the biology of these markers. And it turns out that the body is tremendously efficient in reusing proteins for multiple purposes. So a protein that's important for one thing in one location can be important for something else somewhere else. And so like these heat maps and these molecular pathway maps that you see sometimes published in Nature and Science, where there's lots of the proteins relate to lots of different functions, TNIP2 and IGF-BP7 are associated with a lot of different things, like their names imply. So tissue inhibitor of metalloproteases 2 sounds like something related to inhibiting metalloproteases, and it does. And insulin-like growth factor binding protein 7 actually turns out to be a misnomer because it doesn't actually respond to, it's not actually in response to, it's a growth factor, but it actually doesn't respond to insulin-like growth factors, it responds to insulin. And so it's the one that's unique. But okay, but that doesn't matter. What matters is that the overlap in the physiology for these two markers is they both modulate something called cell cycle arrest, which I didn't know that much about. I'd heard that it was important for the reason that I described in a moment about this, the transition from AKI to CKD, inability of cells to respond to that. But I didn't really understand how important it was or why it was so important. And it turns out that epithelial cells, because they're exposed to the environment, and of course you don't think of the kidney inside being exposed to the environment, but because it's filtering everything that the body sees, it's exposed to that milieu. And because it's an epithelium, it actually retains, despite millions of years of evolution, it maintains all of those responses. The kidney cells respond to UV radiation. And I'm pretty sure that hasn't happened in a long time evolutionarily. Because of this, the cells have a hair trigger response to protect themselves when the environment pressures put them at risk, particularly if the DNA might be damaged. Because the last thing the cell wants to do if the DNA is damaged is reproduce, because if it divides, replicates its DNA, it dies if DNA is damaged. So at the earliest sign of injury, it says, oh, wait a minute, let's be sure. It's like I tell my adult children, I say, look, reproduction is dangerous and expensive. Don't do it until you're ready. And the epithelial cells take that role. So they I think all we're sensing with these biomarkers is we're sensing stress. You know, we're like the psychiatrist for the kidney. Are you feeling okay? No, I'm really stressed out. And that happens before the injury. And that's what's really interesting about this. So what's the evidence to support that? Well, before I get into that, let me just show you some of the rest of the data. So this is major adverse kidney events as well as AKI. So on the top is AKI and the bottom is major adverse kidney events. And you can see there's a response all the way across. It gets a bit noisy at the far end because there's not that many events or not that many patients. But you can see the higher the level of biomarkers, the more likely you are to have AKI in the next 12 hours. And by the way, why did we do 12 hours? In case any of you review any of the subsequent papers, let me explain. The ICU is a busy place. Lots can happen in 12 hours. The biomarker is not a crystal ball. If you go out 24, 36, 72 hours, all kinds of things, new exposures occur. All the biomarker can tell you is whether the kidney's stressed right now because something has happened. Can't tell you whether the kidney's going to be stressed tomorrow because somebody else puts the patient on Pip/Tazo, right? You don't know that. The kidney can't forecast that, and the biomarker can't forecast that. So 12 hours is the only real, but as I'll show you, a lot can happen in 12 hours that we can do. The biomarkers predict acute kidney injury in 12 hours, which is shown there, but also they predict major adverse kidney events, which is death, dialysis, or persistence of doubling of serum creatinine at 90 days or at 30 days. You can also see there's a bit of an inflection point here, meaning that at some point it really the risk really takes off. And I can show you what that looks like here, which is a little easier. So this is the cutoffs that are in the package insert. Actually, I think there's only one cutoff in the package insert. The FDA doesn't like multiple cutoffs, even though we think through multiple cutoffs all the time. So it turns out that the low risk, the low cutoff is 0.3, and that was selected for so what this table is showing you is if you're an analytical chemist, you think about sensitivity and specificity, or you're a third-year medical student. After that, you've forgotten all that stuff. If you're a decision scientist, you think in positive and negative likelihood ratios. But if you're a clinician, you think really in positive and predictive negative value. You might think you're thinking in sensitivity specificity. What you really are thinking is positive and negative predictive value. And so what you want here is a really high negative predictive value. If you're below the cutoff, I want to be able to say, I don't need to worry about this patient. If I'm above the cutoff, I want to say, these are the patients I have to focus on. These are the patients I don't want to give that contrast load to unless I really need to. This is the patient that I don't want to just give them vancomycin and check a level in a couple of days. If I'm going to give them vancomycin, I'm going to check the level right away. So, and I'm going to be very careful about the dosing. So this is the negative, this is the high negative predictive value, and the 0.3 is kind of easy to remember because it has a 97% negative predictive value. So 3, it's not 30, it's 3% risk below the cutoff. Okay, actually at the cutoff or lower. And then 2 is sort of the high specificity, okay, high positive predictive value, and the 2 is handy to remember because it's basically a 1 in 2 chance. If you're a 2 and above, you have a 1 in 2 chance of developing stage 2, 3 AKI, so doubling your serum creatinine, profound oliguria in the next 12 hours. Okay, so really high risk if you're above 2. Low risk if you're below 0.3, and somewhere in the middle if you're in the middle. So we validated those cohorts, those cutoffs in another trial called the OPAL study, and as you can see, it validates quite well. And then the FDA, my friends at the FDA, they made us do another trial, which I was anticipating, but they also made us have a clinical adjudication committee for every single case, which blew my mind. They cited me chapter and verse about every cardiac biomarker has gone through the same process. And I said, really, we have to adjudicate can't we just use KDIGO? And they said, no, you can't use it. It's a clinical diagnosis. In fact, you want to be humbled. You want to be humbled. Have the FDA parrot back to you your own words. They read to me. They said, Dr. Kellum, you said this was a clinical diagnosis, so you have to have a clinical adjudication committee. So we did. We had a clinical adjudication committee of 3 experts who adjudicated every single case. This is the study flow. This is the RSC curve, which is actually better. The RSC curve is actually better when you adjudicate. Why? Because it's a clinical diagnosis. The FDA, it pains me to say it, but the FDA was right. It actually, you need a clinical diagnosis because some people bump their creatinine and don't have AKI. Some people just miss the cutoff and they really do have AKI because they got a bunch of fluid or there's some other mitigating situation. So you want people to make that judgment. This is not in the paper. It's actually coming out in a subsequent paper. But I think it's the money shot for this whole paper as far as I'm concerned. And it's not in the original paper. This is basically the concordance or discordance amongst the adjudicators, right? 3 adjudicators. When they all agreed that it was AKI, you had the highest levels of TIMP2, IGF-BP7. When they all agreed it wasn't AKI, you had the lowest. But look what happens in the middle. When 2 out of 3 said it's and we went with the majority for the primary analysis, when 2 out of 3 said it's AKI and the third said, I'm not so sure. Obviously, that's a hard case, right? The biomarker went with the majority and the same on the negative side. This, to me, if I had any doubts that this test could provide clinical meaningful information, I stopped doubting it when I saw that. But of course, you might round, here at Emory, it's pretty sophisticated, and electronic medical record systems, very, very sophisticated. You might round with a biostatistician, right? And they could do a risk prediction model for you, maybe, right? I mean, I don't know, maybe. Have a computer algorithm, have an app in your phone that can calculate all these things. So this is actually what happens when you use a clinical risk prediction model. You get up to about an AUC of about 0.7. If you add the biomarker on top of that, you get a big lift, and that's highly statistically significant. So even if you're an expert clinician, and there are actually, one of the other things we found out about this is we asked clinicians in a separate project, we asked clinicians to guess whether the patient would develop AKI. And actually, I have to say, there's a lot of clinicians that are actually pretty good at it. A lot of them are terrible at it, but a lot of them are actually pretty good at it. But they don't get a receiver operative characteristic curve much above this. And again, the biomarker adds on top of that. So even if you're really good at predicting AKI, I think the biomarker will add to your clinical acumen. Now, the outcomes, the long-term outcomes are also of interest here, that if you're in the high cutoff of AKI, your risk of death or dialysis at 1 year, or in this case at 9 months, is also quite significant. So we're not just talking about a lab change, not a clinically meaningful endpoint. We're talking about death or dialysis at chronic dialysis at 9 months. But as I mentioned, this is an alarm signal. This is the cells telling each other we're worried, we're under stress. Can we use that to our clinical advantage? So this is what it looks like. If you're in the low risk group, remember I told you the risk was about 3%. It's actually 2.7%. If you're down here, less than 3. If you're 0.3 to 2, that relative risk goes up by 4.2, so it goes to about 9% risk. If you're in the highest tranche, it's 17.4% relative risk, which is how you get up about 50%. So I think that when we can sort out patients that have a risk that goes anywhere from 2.7% up to 50%, that's information that we can use. What would we do? Well, we wrote a lot in the KDIGO guideline about what you can do to manage patients with AKI. It'd be good to start some of that management sooner. We wrote a lot about what to do with patients that are high risk, but not a lot of help telling you how to tell that a patient's at high risk. Remember, we talked about the nephrotoxins, we talked about the contrast, we talked about ensuring adequate resuscitation, and probably just as importantly, ensuring that we don't over-resuscitate. We don't treat them like my houseplants when I was a college student, okay? Because this is the population that's most sensitive, most susceptible to fluid overload. What about in a more specific environment? So this is the behavior. So I work in a cardiothoracic ICU as an intensivist. That's what I do. And so I take care of heart transplants and lung transplants and a lot of quote-unquote routine but very high-risk cardiac surgery, valves, et cetera. And this is what the test looks like in my environment. So this is actually from a study we did in Germany, but this is what it looks like in cardiothoracic ICU patients. The test actually works very well, works better in CT surgery patients than in some other environments. AUC is about 0.86, so it's really quite high. The relative risk above the 3 cutoff, remember it was 4.2 in the big study, it's actually 7. So it's 7-fold increase by going above the 0.3. So it's really this is what it looks like if you graph it out. These are patients who develop AKI on the top, and you can see they have a big increase in their biomarker concentration, and this is with no. So I wondered, when we first put this together, I wondered what we would do with it once it became FDA approved. So I asked my team in the cardiothoracic ICU where I work, and I said, what do we currently do? What's our standard of care for patients who develop AKI? And we all sort of agreed, although it wasn't unanimous. Some people said, I don't bother to recheck the creatinine because what am I going to do? And I recheck the creatinine, but I leave the Foley catheters in. I think pretty much everyone agreed that if the patient develops renal failure, you leave a Foley catheter in to monitor urine output, at least until the point where they're not making any urine. There's no point leaving it in, but at least acutely. I'm very careful with fluids for the reasons that I've just described. I want to give fluids if they're fluid deplete, but I want to make sure they're fluid deplete, and this is why. Because if you have AKI, the kidney can't help you anymore. Oliguria is part of AKI. If you're using oliguria as a means of measuring whether a patient's dry or not, that doesn't work if they have AKI. Do I need to say that? I mean, I can't tell you. You cannot resuscitate yourself out of oliguria. You can't. And so if it's caused by AKI. So the kidney's damaged, then the kidney's an unreliable historian at that point. The kidney cannot help you with fluid management if it's injured. Wouldn't you like to know if it's injured as early as possible? Wouldn't you change your management? I think you would. I certainly do. And I'm not really sure if Lasix hurts the kidney or not. There's a lot of association data. I think it's hard to tease out because we give Lasix to people who develop AKI, and it's hard to know about chicken and egg. But I certainly don't want to give it to patients unless I have to if they have AKI. I give it to patients in the CTICU all the time, but I don't want to give it to patients who I might hurt unless I have a reason to, and so I want to look for that reason. And then, of course, I want to monitor. Sometimes AKI is the first evidence that the patient has. In my setting, in the cardiothoracic ICU, it usually means that either the kidney got whacked in the OR, and I could blame the surgeon, Or the kidney's getting whacked right now, and because we think the heart's normal, because that's what the last echo showed, but they're tamponading. Think about that for a second. So, I will routinely look at cardiac function in patients who develop AKI. But if I'm 12 hours behind the 8 ball because I'm waiting for the creatinine to go up, I'm going to sit on a tamponade for 12 hours? I hope not. So again, all of that becomes important. And so it all sort of fits into this risk model. So if they already have evidence of AKI, then I don't need anything else. They're high risk. If they already have an elevated creatinine, we're done. If I have really high clinical suspicion, I'm one of those really good doctors, and then fine, you're already high risk. We're done. If, on the other hand, neither of those things are true, and you have a level of biomarker that's elevated above the 2 cutoff, you're very high risk. If you're above the 3 cutoff, you're moderate, and you could even say moderate to high risk. I mean, a 7-fold increase in relative risk is probably more than moderate, but if you're below 3, you're low risk. And so we think that translates into a bunch of things that we do, and we make these decisions all the time. How about, put the patient back on their ACE inhibitor and send them to the floor? Put them back on their ACE inhibitor, send them to the floor. Do you make that decision differently when the patient has AKI or not? I think you do. Can you make that decision 12 hours sooner with a biomarker? I think you can. So, I think those are where all that kind of information comes into play. But now, finally, let's go off the ranch. Let's go off the ranch a little bit. Because this is remember I told you this was a protective mechanism. Wonder if we could induce it. Wonder if we could trick the kidney into protecting itself. Is this an inducible response? Now, we're working on developing, drugs based on these markers, but that'll take years and years to get to anywhere, right? It'll take years and years to have a recombinant, TIMP2, IGF-BP7. But in the short term, can you trick the kidney into responding in this way to defend itself? And it turns out that you may be able to do that. This is a paper we published in JAMA last year. And what we did was we randomized people to receive something called remote ischemic preconditioning. What we did is we blew a blood pressure cuff up on the arm to 200 millimeters of mercury, or at least 50 millimeters of mercury above their systolic pressure. And we left it there for 5 minutes. We took it down. 5 minutes later, we did it again. We did that 3 times. And that's actually painful. I've done it to myself. And your arm really gets pain. It's really sore. So we did it under anesthesia. So we brought the patients in, put them under anesthesia, did this maneuver, or we did a sham maneuver where we put the blood pressure cuff on. Everyone in the room thought the patient was getting the maneuver, but they didn't get any inflation. They just was just inflated enough to have the air in the bag. And that's what we did. And what we found was we had a profound decrease in these very high-risk patients. There have been other trials that have done low-risk patients and not found the same result, possibly also because those trials used propofol, and propofol interferes with this mechanism for reasons that we could talk about. But what we did was we did off propofol, we did remote ischemic preconditioning high-risk patients, and we had a profound decrease in the risk of AKI. The rates of AKI dropped from about 50% down to 37%, statistically significant result. Rates of renal replacement therapy were lower. Intensive care days were reduced with the therapy. Why is this happening? Well, you blow a blood pressure cuff up on the arm, and in patients that got remote ischemic preconditioning, well, let's look at the controls first. If you got no remote ischemic preconditioning and you develop AKI, you have exactly the same pattern. So this is the ones that got AKI, and these are the ones that didn't get AKI. And you can see it looks exactly like that prior paper that I showed you in terms of the biomarker associated with AKI. If you got remote ischemic preconditioning, you get this increase before the surgery with the blood pressure cuff. You get and it's not a big signal. It's not like you get with the surgery, but you get a little warning shot. Tells the kidney that something bad is about to happen, and before the badness actually happens. So here's what that looks like. This is remote ischemic preconditioning. This is sham. You squeeze the muscle and releases some myoglobin and some HMGB1 and maybe some uric acid and God only knows what else. And that goes to the kidney, and the kidney sniffs it out. Kidney says, oh my God, something bad is about to happen. Tell your friends. And everybody ducks and covers. And then the bad thing happens and there's less AKI. Versus the sham, where you do the maneuver, but nothing gets released from the muscle, and the kidney's just sitting there and then gets whacked and develops AKI. We tested this by looking at urine HMGB1 in the kidney, in the urine. It's higher in the remote ischemic preconditioning group. We've done cell culture work where we stimulated the cells with HMGB1 and they secrete TIMP2 and IGF-BP7. So I think this is real. Will we be able to utilize it in patients? I hope so. We're putting trials together right now. So I'll conclude by saying damage-associated molecular patterns and pathogen-associated molecular patterns activate epithelial cells, dendritic cells, T cells. I didn't go through all of that mechanism with you, but that's what AKI is all about in the vast majority of our patients. Yes, we do have a few patients you put a clamp on the renal artery, or they've been at home in shock for 3 days because they didn't have health insurance. Hopefully that doesn't happen now with health insurance. But you know, we do have profound ischemia for some patients, but most patients is because of damps and PAMPs and inflammation. Arrest of cell function results in a loss of GFR through tubular medullary feedback. That's why you develop oliguria. That's why you develop azotemia. Markers of cell cycle arrest appear to be robust measures of risk for AKI in the next 12 to 24 hours. This has now been validated in more than 2,000 patients. It's FDA approved. The underlying biology suggests an alarm phase marker before injuries actually occurred, and giving you, the clinician, 12 hours lead time to do something about it. There's a potential to exploit this mechanism, and I say potential because it's just one trial. We need to do more work. Using something like RIPC to increase TIMP2 and IGF-BP7 and protect the kidney from subsequent injury. And with that, I thank you for your attention.